All right, so I'm going to kick it off. Welcome, everybody. I'm John Kelly, and delighted to be here. Thank you for coming. Happy Friday, everybody. We've got an action-packed webinar today. Welcome. Just to let you know, for those of you who are new, this is a NIDA-sponsored series that we're doing, which is part of an initiative to expand the research infrastructure around recovery support centers for people who are taking medications for opioid use disorder, as well as people more broadly with opioid use disorder and other substance use disorders. This is our great team. Dr. Bettina Hoffman is the co-principal investigator, Bettina, as well as this fantastic team here. Next slide. Just to let you know, we are doing a nationwide survey of recovery community centers. You can see our progress here on the right, making good progress, but would love your support. So if you're out there, a recovery community center, look out for an email from us with a link to complete the survey. If you haven't got a link, please email us so we can send you a link to complete it, because we really need your support here to get this information. So thank you for that in advance. Next slide. And this is just to let you know, our next webinar is coming up on December 3rd and January 7th. Thanks to Hazel here, who's done a fabulous job presenting it in such a nice, unique way. And we have one on tele-recovery as well in February. And with that, I'm going to turn over to our live spotlight feature, which today is from right here in Massachusetts at Spiritworks. So over to you.
Okay, thank you. Could I share my screen? All right. Okay.
There we go.
Is it big now? Oh no, here we go.
Yeah.
So good afternoon, everyone. And my name is Caitlin Johnson. I'm the outreach worker at Spiritworks Recovery Support Center, and I'm here with my coworker.
Hi, I'm Lorraine Barton, the recovery coach at Spiritworks Recovery Support Center.
Spiritworks is located in Roxbury, Massachusetts, in the community of Roxbury. Boston community of Roxbury. Okay, who is Spiritworks? Spiritworks is a peer recovery support center providing resources and services to individuals 18 and older, as well as to their families and loved ones. These services include mutual aid support groups. Spiritworks supports multiple pathways to recovery, and some of these include All Pathways to Recovery, NAMI Connections, which is dual diagnosed group, Women's Support Group, Life Ring Secular Recovery, and a nurturing program for families with substance use disorder. Also, we have recovery coaching.
And hi, I am the recovery coach. And as a recovery coach, I am someone who supports people who are seeking or who are in recovery. As a recovery coach, it is my honor to help recoveries identify and remove barriers to sustained recovery, no matter their recovery pathway. As a motivator and ally, coaches help recoveries uncover their obstacles. We are guides, we are mentors, we're resource brokers, we're advocates.
We also have volunteer opportunities, stipend positions, educational opportunities, community resources, social events, and recreational activities. And we have been connected and will continue to be connected to our members through our social media platforms and mobile app.
Participatory model. Spiritworks is a participatory model which ensures that our members are actively involved in making decisions. Spiritworks members are afforded the opportunity to build their own unique individual, social, and community support. These opportunities help prevent relapse and promotes long-term recovery from addiction. I would like to take this opportunity to speak to the topic at hand, MOUD. As a recovery coach and a woman in long-term recovery, I've spoken with dozens of people who are in recovery utilizing MOUD. They've spoken of how they've been able to stabilize their lives, rejoin their families, create families, maintain jobs and careers. I can assure you from personal experience that people you've met in your daily walk are utilizing the MOUD path. However, many choose to be anonymous due to the ostracization that has been imposed on those who have chosen this path. We sit in recovery groups with them. They are our mailman, our barbers, our landlords, our business owners. They are our recovery coaches. Please try to erase the images that have been bored into our minds over the years regarding MOUD. Look around your world. This is where they are. Thank you.
We would like to thank you all for being here today and allowing us to use this platform to introduce Step Rocks. MOUD is considered one of the many pathways. MOUD has changed many lives. However, there's still a large amount of stigma around MOUD and even stigma within our own recovery community. So today I just ask that everyone listens with an open mind. And if you have any questions, please email us. We're going to put our emails in the chat as well as the rest of our contact information. Thank you.
Awesome. Thank you guys so much. That was a perfect introduction to our today's topic, and I love hearing about Step Rocks. For those of you who've been here many times, you know our next step, and that's going to do a polling question. Our goal really is to have a multi-stakeholder group come together to inform the building science really of recovery community centers. So if you could all take a moment right now to complete the poll that's popped up. There's a number of questions here, some about who you are, and then 3 questions specifically pertaining to the presentations you'll be seeing in a few minutes. There is a little thing on the side where you can scroll down. So if you could take a moment to do that right now. And we will be displaying the answers to these questions, not from who they come, but in terms of the percentages. So you can all see what everybody else in the room, where the majority of people answered. And once you're done with all 7 questions, there should be a blue submit button that lights up. All right, Hazel, how are we doing in terms of getting answers?
It's a pretty long poll, so we only have 50% so far, so I'll give it another minute.
That's fair. There's a lot of words on the screen this time. So Hazel, if you could advance to the next slide, I'll say a few words about the format, and then we'll have our answers. So as you all know from registering, what we are going to have is we're going to have 2 scientists present some findings from the field that hopefully answer the questions we just raised for you all. And then we'll have 2 RCC directors present the views from what it looks like in reality from their perspective. So leading us off today is going to be Dr. Roger Weiss, professor of psychiatry at Harvard Medical School. After him, we will have Dr. Lauren Hoffman, who is a postdoctoral fellow within our own Recovery Research Institute. Next is Wendy Jones, who I hear now has audio capabilities again, which is wonderful, the Executive Director of Minnesota Recovery Connection. And then Dan Brown is going to speak, the founder and Executive Director of Spiritworks Foundation. And then after the four of them are done presenting, we're going to open it up to Q&A and comments. We'll try to stop at 1, and certainly feel free to leave when you want. We will also stick around a couple of minutes longer if we get engrossed in our discussion, as we so often do. How are we doing on the poll?
I think we're good now, so I'll share the results. And it should pop up on a window in everybody's screen, so you can scroll down and see all the responses.
All right. So we see here that we do have quite a few of the highest. We have here the scientists and recovery advocates here. We do have some healthcare decision makers in the rooms as well. And of course, we have RCC participation, which is great. And we do have a few prescribers as well who can field questions for us. Let's see, and regarding specific questions that we asked you guys in terms of what they mean, and the most common answer was a better chance to survive. And life-saving medications we often talk about. And then the one with the fewest responses was in regard to having better mental health. But all of these categories were endorsed actually fairly highly by more than half of us. And then we have, what percent of RCC's attendees do you think have positive attitudes towards medications? And here the most frequent response was 50% tied with 70, so very, very positive views. And how long should somebody stay on medications for opioid use disorder? And here the most common response was until symptoms resolve. And now, whether or not that's true, we will have Roger Weiss telling us the lay of the land and the facts. Roger, over to you.
Okay, thanks very much. I'm going to give a sort of a whirlwind 10-minute discussion of a complicated topic, but I'll do the best I can in 10 minutes on medications. If I can get the next slide, please. So there are 3 major FDA-approved medications for the treatment of opioid use disorder. There's methadone, which is a full agonist, meaning an opioid-like, a full opioid. It's available only through specialized opioid treatment programs. Buprenorphine, which is a partial agonist, so it partially activates opioid receptors, and it can come in sublingual or under the tongue tablets or films, often along with naloxone to discourage injection. Injectable, subcutaneous or under the skin, long-acting buprenorphine. It's a monthly formulation. A new formulation hopefully will be approved soon that also includes weekly, and an implant for 6 months, which is used very rarely. It can be prescribed in office practice, unlike methadone. And if I can get the next slide. And the third one is naltrexone, which is an opiate antagonist or an opioid blocker. It has no opioid properties. It can be given either orally or via a monthly intramuscular injection, gluteal injection. The one difference between methadone and buprenorphine on the one hand versus naltrexone on the other hand is that a patient needs to be detoxified and opioid free for somewhere in the range of a week or 2. It can vary a little bit before you can initiate naltrexone. And naltrexone can be given in office practice with no special training or waiver needed. Next slide, please. So this slide gives you shows the amount of opioid activity in these 3 medications. If you look at methadone in the red, essentially the more methadone you get, the more opioid you get. If you look at the blue, the bottom horizontal line, naltrexone, there is no opioid activity. And buprenorphine, you get some opioid activity, not as much as methadone. And you can see that it plateaus after a while, which is somewhere in the range of 32 milligrams. If I can get the next slide, please. So how effective are medications for opioid use disorder? So the bottom line is that medication saves lives. People can die when medication stops. This slide shows the all-cause mortality per 1,000 person years in and out of treatment. If you look at the blue and the red on the left, this is people who are in treatment. The blue is in the first 4 weeks, the red is after that. Then people go out of treatment and you see that it goes up by about 7 times in the first month after people get out of medication treatment. It goes down after that, but it's still more than twice as high as for people while they're in treatment. Next slide, please. I'm going to give you the results of 2 studies that were done to illustrate the efficacy of medications. One is the prescription opioid addiction treatment study, which I had the pleasure of leading. It was the largest study of treatment of prescription opioid dependence, 653 patients at 10 United States sites, and we studied different lengths of buprenorphine, naloxone, or Suboxone, and different intensities of counseling. And a successful outcome was considered abstinence or near abstinence from opioids. The first part of the study, we just gave people a 4-week taper off of whatever they were taking. And the number of people who got off of opioids as the result of doing that, only 7%. For people who relapsed to opioid use as a result of that taper, they were put back on buprenorphine for 12 weeks, and we measured success on buprenorphine, and the success rate was 49%. So it's 49 versus 7. After being on buprenorphine for 3 months, they were tapered off again and followed for another 8 weeks and down to 9% success rate. So the difference on and off buprenorphine was gigantic. Adding counseling to buprenorphine and weekly medical management did not improve outcome in this study, and I'll talk a little more about that in a minute. Next study, one other study that looked at sustained release injectable buprenorphine versus placebo. So this is sublocade, and so people were given 6 monthly injectable buprenorphine shots and compared to people who got 6 monthly injections of placebo. They all received individual drug counseling. Successful outcome was defined as at least 80% opioid-free weeks. The success rate on buprenorphine was 28%, not optimal, but compared to placebo, 2%. So you can see the dramatic difference on and off medication. Next slide. How do these medications compare with each other? Next slide. So comparing sublingual buprenorphine versus methadone, both medications are highly effective, although buprenorphine has a greater safety profile. Both have reduced opioid use and reduced mortality. In general, there's better retention in treatment with methadone. The results regarding opioid use are mixed. Some studies favor buprenorphine, some studies favor methadone, some show no difference. The context and the setting of the treatment, though, is very different in the United States in an opioid treatment program versus office-based practice. Next slide, please. What about sublingual buprenorphine or Suboxone versus extended release naltrexone or Vivitrol? Both medications are equally effective once people start them, but the big difference between them is that starting extended release naltrexone is challenging because it requires detoxification and opioid abstinence of a week or sometimes a little more. 30% of patients in the United States multi-site trial that compared buprenorphine versus naltrexone, they never received a dose of naltrexone because they didn't do that. And that's fairly typical that many people who intend to get onto extended release naltrexone never do. So a major challenge is to find optimal ways to get patients from opioid use to naltrexone. It's called the induction hurdle. Next slide. So how do you choose a medication for opioid use disorder? One sort of simple way to think about this, buprenorphine is easy to get on. You can be using opioids today and on buprenorphine tomorrow, but it's difficult to get off if you've been on it for a long time and you decide you want to get off of it, which may or may not be a good idea. We're not going to get into the details of that right now. It's difficult to get off. Naltrexone is difficult to get on and easy to get off. Both easy off and difficult off are mixed blessings. For people for whom it's a bad idea to get off, it's not good that it's easy to get off of naltrexone, and it's kind of a good idea that it's hard to get off of buprenorphine. On the other point, people who have been stable for a long time and feel like it would be a reasonable thing to try to get off. The fact that it's so hard to get off of buprenorphine isn't necessarily a good thing, and easy to get off of naltrexone is a good thing. So it's a mixed blessing. It's not good or bad to be easy or hard to get off. A big challenge is getting off of opioids and onto naltrexone. Methadone has a built-in structure of the program, for better and for worse. For some people, the structure of the methadone program is extremely helpful. For others, the fact that they have to go every day for a long time, and sometimes it could be a long way from where they live to get to the program, that can be a real problem. The big difference is between an agonist and antagonist. Many patients or their family members have very strong feelings that they want one and not the other. As far as I'm concerned, whatever people will accept is good. These are all effective treatments. If people choose one and not the other, I wouldn't try to talk them into or out of the opposite. And it's got to be a collaborative process between you and the patient, and sometimes the family as well. Next slide, please. Buprenorphine and behavioral interventions. Next slide. 4 major studies have shown that adding counseling, standard counseling, to buprenorphine and medical management is not superior to buprenorphine and medical management alone. Many patients do well with buprenorphine and medical management. Those with co-occurring psychiatric illness do better with extra treatment. People with greater severity generally do better with additional behavioral treatment. However, it's hard to predict who will require more treatment and who doesn't. Many patients don't want extra treatment. Mutual health groups such as AA or NA have been found to be helpful in long-term opioid use disorder studies, and almost nothing is known about behavioral treatment plus naltrexone. Next slide. How long should people stay on medication for OUD? Next slide. The National Quality Forum, which is an expert consensus, not an empirical study, based on commercial claims data from the RAND Corporation study. So one quick fact to know how RAND got its name, it's R&D. So they recommend at least 6 months of continuous pharmacotherapy for MOUD as a quality measure. Next slide. The best study that's been done was a study out of the United Kingdom. They examined data from over 50,000 patients who received publicly funded OUD treatment in the UK. 22% were able to successfully discontinue buprenorphine and not seek treatment again within 6 months. Those who had been in treatment for over 2 years tended to do better. Older patients, employed patients, and people who didn't also use crack also did better. Next slide. No prospective studies, however, have been done to look at length of buprenorphine. The idea of stopping MOUD should come from the patient, not from the treater. So clinicians should not say, I think it would be a good idea for you to stop buprenorphine, but patients often will, and then it should generate a discussion, not necessarily start tapering that day. It should be shared decision-making with a clear discussion of the risks, including overdose, And I'm currently co-leading a study, which is the first prospective study of buprenorphine discontinuation, called the Retention Duration Discontinuation Study, for the first prospective study of discontinuation of people who have been on MOUD for a while and are stable and want to come off. It's funded by NIDA and the NIH HEAL study. Next slide. I think that might be the last one. Yep, thank you.
Wonderful. Thank you, Roger. Lauren, you're up next.
Okay, let me share my screen here. How's that?
Looks
Great.
good.
Okay, good. All right. So, thanks for having me. I'm going to keep it pretty brief too, about 10 minutes, but I'm really excited to talk to you all about attitudes towards opioid use disorder medication treatments, because we have some really exciting data in the context of recovery community centers, which I'll also refer to as RCCs for short. So there's been an increase in the availability and the use of all three medication treatments for opioid use disorder over the last several years, including agonists like methadone and buprenorphine, or Suboxone, for example, as well as antagonists like naltrexone or Vivitrol, these opioid blocking medications. Despite these increasing trends, though, and the proven efficacy of these medications, evidence also suggests this persistent unmet need for medication treatments for opioid use disorder, with only about 20% of people with opioid use disorder receiving specialty addiction treatment in a given year. So the question is why? Why is there this ongoing unmet need at such a high rate, given this expanded access to medication treatments and all of our efforts? And research has identified several barriers to medication receipt, including institutional, provider, policy, and financial barriers. And at the individual level, many potential barriers have been acknowledged, but there are few systematic studies on the topic. And one of these understudied individual level barriers is attitudes towards opioid use disorder medication treatments. In particular, we know relatively little about medication attitudes from the perspective of individuals with lived experience of addiction and recovery. And we all know that this group is a really important subset of stakeholders in the dissemination of medication treatments, because they're likely to have an impact on their use and the provision of these treatments. And personal attitudes towards these medications can also influence one's own treatment and recovery pathways. So, for example, studies have shown that negative attitudes towards a particular medication can deter a patient from using that medication or selecting it, and positive attitudes towards a medication that someone's taking is usually associated with better treatment retention. So there are clinical implications here. Most of what we know about medication attitudes in the recovery community is based on clinical commentaries, a few qualitative studies, and anecdotal evidence, which would generally lead us to believe that medication attitudes are probably, more or less negative in the recovery community, particularly for agonist medications, because we all know that some individuals can misinterpret these treatments as replacing one addiction for another, which we know is not the case. Rigorous research is lacking in this area, but thus far reports suggest that between about 20 to 50% of recovering individuals in these various subpopulations have positive attitudes. So it looks like in general, potentially negative attitudes could be more prevalent than positive attitudes, at least in these particular recovery populations. But the methods, the populations they're looking at, the outcomes of interest, these all vary between these reports, and it really prevents us to make a formal conclusion. Regardless, we wanted to know about medication attitudes within recovery community centers, because we thought they could be they could offer a really promising venue for fostering support of individuals who are receiving these medication treatments. And this is because we know that RCCs are especially inclusive, right? They don't follow any particular recovery model. They operate under the maxim, many pathways to recovery, all should be celebrated. And at least in the New England region of the US, we know that RCCs are frequented most often by individuals with a primary opioid problem, with about 41% shown in red here, reporting opioids as their primary substance within these RCCs. And to give you an idea of just how prevalent opioid use disorder or opioid recovery from opioid problems is at these RCCs, the figure on the right here shows the prevalence of primary substance use problems among a nationally representative sample of individuals in recovery in the US. And this stems from Dr. John Kelly's National Recovery Study, which shows that about 5% of the general recovery population has a primary opioid problem versus 41% at RCCs. So this is really emphasizing that this cohort is generally the minority in the general recovery population, but the majority at RCCs. So the inclusive nature of recovery community centers, the high prevalence of members with a history of opioid use problems, we thought might offer this environment that's supportive and accepting of individuals who are on medication treatments for opioid use disorder, but we really don't know much about medication attitudes in the context of recovery community centers. So to get at this question, we recently published a paper addressing medication attitudes among RCC attendees. And this data stems from a cross-sectional survey of 336 recovering adults attending one of 31 recovery community centers in the New England region, with about half the sample in their first year of recovery. And as part of the survey, participants were presented with 4 statements regarding 4 different medication treatments. The first 2 here concerning opioid use disorder medications, and then these latter 2 concerning alcohol use disorder medications, and then mood disorder medications. And all statements communicated that it was a good idea for someone with an opioid, alcohol, or emotional problem to take a medication to help with their problem. And for opioid medications, we specifically looked at agonists like Suboxone and methadone, as well as antagonists like naltrexone or Vivitrol. And participants indicated their level of agreement with each of those statements on a 1 to 6 Likert scale. And then we dichotomized those responses such that any level of agreement was deemed a positive attitude, and any level of disagreement with that statement was a negative attitude. And lo and behold, we found primarily positive medication attitudes at recovery community centers for all medications. So what you're seeing here on the far left is agonist medications or attitudes towards these agonist medications, and then the percentage of RCC attendees who had positive attitudes or negative attitudes towards them. Positive attitudes shown in blue. Next to that, you're seeing antagonist medications like for opioid use disorder, like Vivitrol, for example, and then medications for alcohol use disorder and mood disorders. And for all these medications, positive attitudes were more prevalent than negative attitudes, which is really exciting. But my next question was, how does this compare to the general recovery population? If we were to, use the same survey items and the same statistical methods, in which case we would have more of a direct comparison. Luckily, Dr. John Kelly also did the National Recovery Study and included the same questions or items about medication attitudes. And this really allows us the opportunity to make this direct comparison. So really quickly, this study was a survey of a nationally representative probability-based sample of individuals who self-identified as having resolved a significant alcohol or other drug problem. Data were collected from approximately 2,000 people in 2016, and the data were weighted to accurately reflect the US population. So we took a look at data specifically concerning medication attitudes from this survey using the same exact methods that you just saw for the RCC data. And this is unpublished data, but ultimately we found a 50-50 split in positive and negative attitudes. So side by side, you can see just how much more positive these attitudes are towards agonist and antagonist medications in RCC members relative to the general recovery population. All right, so in summary, opioid use disorder medication attitudes might be more positive than we presumed, right? We're seeing this 50-50 split. in positive and negative attitudes among the general recovery population. And so this kind of begs the question, are we hearing more about the negative side of medication because most people really have negative attitudes? Or is there really just a vocal minority or subset of folks who are extremely vocal about their negative attitudes, perpetuating this perception that attitudes are more negative than they really are? And that's not entirely clear. We probably need a little more verification of that. Regardless, though, these data do suggest that RCCs are clearly surpassing the general recovery population in the US in terms of positive medication attitudes. And RCCs in their culture, in my opinion, clearly hold potential for really, truly welcoming and equally supporting and advocating for those who are on medication treatments as part of their recovery journey, and possibly much more so than the general recovering population. But of course, we need to hear from the boots on the ground. Is this true in your guys' experience? Are recovery community centers really a good fit for supporting individuals who are receiving medication treatments? And to speak to that, I'll turn it over to Wendy, but would love to hear from you all at the end if we have time as well. Oh, and thank you to everyone who contributed to this research.
Thank you so much, Lauren. That was amazing.
Yeah.
Wendy, are you ready for us?
I am. Can you hear
Wonderful.
me?
Wonderful. Yes, we can.
Great. So I think Hazel's going to run my slides. And while that's getting set up, I'll just say, pleasure to be here. Thank you for having me. My name is Wendy Jones. I'm the Executive Director of Minnesota Recovery Connection. I am a person in long-term recovery. I am in recovery from an alcohol use disorder, so I do not have personal experience with MOUD, but I can speak to my recovery community organization. Just a quick refresher, we call ourselves an RCO. We are a nonprofit led and governed by members of the recovery community, non-clinical, inclusive, honor all pathways. We really exist to offer free services, low threshold access, and provide assertive linkages to system support. So kind of a one-stop shop for recovery. So next slide. Minnesota Recovery Connection specifically, we were the first recovery community organization in Minnesota, established in 2010. We're headquartered in St. Paul, and we do provide direct peer-to-peer recovery support services in the Twin Cities metro area, but we also serve a statewide education and advocacy function. We have 7 full-time employees, 15 part-time employees, and about 40% of our current staff has lived experience using medications for OUD. We do have about 350 active volunteers. Currently do not know how many of those have lived experience with MOUD. I would think more lean heavily on alcohol use disorder, but we have a real mix of people from different backgrounds. So next slide, please. So I was asked to talk about how do we handle medications for opioid use disorder? And it really manifests itself across our 3 arms of service: direct support, public education, and advocacy. Next slide. And so the direct support, providing that one-to-one peer support, that's probably the most complex area of how we handle MOUD. And it spreads across the people at our recovery community organization all the way to the direct programs that we offer. And so the first really critical part of providing an environment that is friendly for people on MOUD is how we bring people on board. And so our hiring processes for both staff and volunteers are we really emphasize all pathways. And if someone can't wrap their head around all pathways, we just want to make sure that that might be a barrier for them to be engaged in the recovery community organization. So all pathways, including harm reduction and MOUD, are really emphasized throughout that onboarding process. All of our staff, regardless of what position they hold, even if they're not a peer recovery specialist, we do have them go through our 46-hour Recovery Coach Academy, which is inclusive of all pathways. And our volunteer onboarding also includes that. So you bring in the people, but do you create a culture that's supportive of MOUD? So it's often a part of our staff conversations, sharing of stories. We have frequent guest speakers. We promote resources on site. And we really hold each other accountable for recovery-friendly language that honors all pathways. We really never use the word sober, for example, or clean. Obviously, clean is a very stigmatizing word. Sober also has a connotation that you are not using a medication. So we talk about recovery. We don't talk about sobriety. The environment of our physical space, it's very important to us that we have provider brochures, resources. We have those on our website. We are also a naloxone distribution site. We have posters, positive imaging on site. And then the programs that we offer include the one-to-one coaching and resource navigation, specifically for people using MOUD. We provide a number of all recovery meetings, which focus on recovery capital, not a particular pathway. And we partner with a lot of organizations like the Aliveness Project, the Steve Rumler Hope Network. We have HIV testing on site. So there's a real direct effort to bring in partners that are supportive of MOUD. And we do a lot of outreach to MOUD providers. So next slide. The public education aspect of our work, we're the state's leading trainer of peer recovery specialists. It's a 46-hour training. There is a full half day in that training dedicated to MOUD and harm reduction. I know those are two different things, but they often get talked about in the same conversation, but it's really opening people's perspective to what recovery looks like. We do a lot of CEUs for peer recovery specialists, including a 3-day harm reduction training. We foster a peer support alliance in the state, regularly featuring MOUD providers and topics as part of the monthly CEUs through that organization. And then we have some signature events that promote all pathways, like our Walk for Recovery, Rally Caps for Recovery is a Minnesota Twins game. But again, the emphasis is always leading with all pathways. Everyone is included, everyone is welcome. Next slide. And then advocacy, we host an annual recovery advocacy seminar, Recovery Day on the Hill. We do a lot of legislative relations, again, often coming back to that topic of all pathways and MOUD. So next slide. So what do we hear? What do we hear from our community members? Do we have any negative reactions? I think that what we do here is repeated stigma. Our participants do report that they're often excluded from mutual aid groups, including NA, and that they will not disclose that they are on MOUD. They have a fear of sharing. Many have been excluded from recovery residences because they are using medication. And they report that it's difficult and humiliating to obtain and sustain prescriptions. The policies are punitive. They're not recovery-friendly environments. So that's a frequent conversation among our participants. We've also noticed there's just general ignorance about the topic. A lot of our trainees, actually most of our trainees, come into it with very little knowledge of MOUD or harm reduction or all pathways. And those attitudes that people bring into it can sometimes be a barrier to learning. That's something we really have to work through in the training, is to get people out of their AA mentality. So, and then challenges that our peer recovery specialists often report is in working with people using methadone, particularly that they can present as being fuzzy or high. And so that sometimes is a challenge in removing that barrier that you might have to work with a participant. So recognizing that a person might be using medications and that's why they're presenting that way. And that there's a lack of accessible, easy to understand information. We've also noticed, even with our own staff, it's a challenge. Some of our staff members have gone off Suboxone because it's expensive and they want to go off it over time. They've lost work. They feel terrible. It's not easy to withdraw from an MOUD. And so that's a conversation that we have in the workplace, is acknowledging that you might feel that way, and we're going to support you through that process. So next slide. So the last thing that I'll talk about, it was asked, how can you help? How can the scientists help? The healthcare industry help? How can policymakers help? And the first thing that I always come back to is make every action and decision start from the fact that this is a health condition, not a moral failing. I think that permeates all of this conversation. Is it's still very much presented as something that should be treated differently, that there's a punitive tone to it. And a lot of that comes from ignorance. And I really wish that everyone at all levels in every field was required to complete ongoing substance use disorder and recovery education, and have it taught by or with actual community members, people who have that lived experience to walk alongside the scientists and the doctors, because I think that's the most effective way to make this a very real conversation for everyone. And then the last couple items here that I really wish people would do is can we integrate substance use disorder health into mainstream primary care? Isolation and separation of SUD care and medications for opioid use disorder, it reinforces stigma. And quite frankly, it promotes poor quality services. There are a lot of not so great services out there that play to people's personal shame and their fear. And I think the more that we integrate this into healthcare, the more we can remove that and help more people recovery. And finally, my last pitch, make it affordable. Cost is a significant barrier, and insurance isn't very helpful in this situation. So there you go. Thanks so much for letting me join you today.
That was amazing. Thank you so much, Wendy. Jen, you're up.
All righty, thank you. And thanks for having me. I too am a woman in long-term recovery. I the founder and executive director of Spiritworks. And our mission at Spiritworks is that together we are working to break the intergenerational cycle of addiction in families by educating, equipping, empowering, and celebrating individuals, families, faith leaders, and communities on their journey from addiction to recovery. And so not only do we work with individuals with addiction and recovery themselves, we also provide recovery support services to family members. Next slide, please. So I too was asked the same questions and offered that Wendy had, and what we found is very similar to what Wendy said. So in terms of directly answering some of those questions, what we believe at Spiritworks is that there are not only many pathways to recovery, there are also many pathways of recovery, which means that we all don't get to the same place in the same way, and we don't all maintain our status of recovery in the same way. We too at Spiritworks talk about taking medications, much like somebody would take another medication to treat a different illness. We take medicine, we're not on medicine, we don't use medicine. Those aren't the kinds of words and language that we hear with regards to people who have different types of illnesses. They take medication. We have many conversations about why we as the individual taking the medication, as well as our community members, get so upset about other people taking medication. And what we found as well is the ignorance, the discrimination and prejudice. We also have found a lot of what we term internalized stigma. And a lot of that comes from not understanding our own issues with addiction and recovery. And so this is an area of real growth that, and certainly attention that we have had to pay. Next slide, please. So what services and resources do we have and have we implemented? We do a tremendous amount of training. Wendy mentioned that as well for where she is, but we do training specifically on multiple pathways. We do a Recovery 101 training, which allows people to look at their own attitudes towards the different pathways. It's easy to say that we honor and value multiple pathways until we're offered the opportunity to really look at what some of those different pathways are. We also know that different cultures you know, in the African American community, that we have a tendency to look at recovery from a position of abstinence. And so all of those things are really helpful in terms of helping understand and helping people to understand differently. We have an educational site where people can go, and what's wonderful about our provisions for the Journey site is that it is curated. And so what we have done is point to all of our scientists and other experts. So this will take you directly to the work of Dr. Kelly. It'll take you to NIDA. It will take you to some of those other sites where we don't have to be the experts. We will point you to the experts. Next slide, please. So some of the things that we hear our members and participants telling each other. Again, I think Wendy mentioned some of these. We hear that you're not really clean if you're taking medicine. We hear that the people are still using, and that they're using their Suboxone or methadone rather than that they are taking it. We too hear that people who are on Suboxone are nodding off in meetings. And one of the things that we've learned is that when people are on the proper dose of their medication, they don't nod off, go figure. And we also hear a lot of times that people are abusing their Suboxone and getting high off of it. And again, we point to the science, because we know that if it's taken in the right way, that certainly isn't what's happening, or mixing it with something else, which typically is what we see. Go ahead to the next slide. So we also hear, and I think for us, this is where the good news has come in. We hear other members saying that people need to take medication to manage their illness, to get well and to stay well. We also hear from the family members that we provide support to, who have lost their loved ones, who have died, that they would gladly give their children medication if it would bring them back or give them a few more years with their loved ones. So I think the point here is the recognition that it's not only an issue with individuals in recovery, it's also an issue for family members, and family members need that education and support as well, in terms of, you know, they've heard a lot of the war stories and the misinformation. And so being able to always include family members as we're having these discussions. Next slide. Or not.
Can you guys not see my
There we
screen?
go. Perfect.
Oh, perfect.
So one of the things that I find to be particularly interesting is this notion of what people like or dislike about taking medications. And certainly we hear those who don't like taking medications at all. And I often have fun when I hear people saying that they don't like taking medicine or they don't trust medicines. And because I'm in recovery, I get to remind them that some of us used to go to places we had no business being in, and engage with people we have nothing in common with, and buy something out of a plastic bag that we're not really sure what it is, right? And so when we get honest about that kind of behavior, you know, we really see that it's usually about something else, right? That we have a bias or a stigma about why we would take medicine instead of not taking it. And so a lot of times through having and engaging in these conversations, we're able to break through some of this notion of I don't trust it, or I don't like taking it, because we certainly, I know I was willing to take just about anything when I was in my active addiction, and I didn't go and try to figure out the efficacy of using drugs. So the other piece, I think, which is really helpful for us at our center, is that I have personal lived experience with taking naltrexone. I took it for about 9 years. I took it as a woman in long-term recovery. I had sustained a traumatic brain injury, and so was having a tremendous amount of stress in my life, and traumatic brain injury, and my physician prescribed it as part of my healthcare delivery system. And what I know from my own self is that not only did I remain abstinent from opioids and alcohol during that time, You know, the things that we talk about in terms of recovery capital also improved, right? So my quality of life was better. My self-esteem was better. I was happier. Over time, I was able to no longer be on disability. I was able to return to work and do those kinds of things like other citizens, which is what I had always desired to be in the first place. And finally, I think for me, I don't think it's anybody's business, frankly, in the mutual support rooms and things like that. You know, unless I or others choose to share it with people. I mean, we don't seem to get so upset over people who are taking Lipitor or taking other medications. We have this bias against medications for opioid use disorder. And so I think we need to take a look at that, especially as we are asking others to make this a part of the healthcare delivery system, that we too in recovery need to understand this as a health issue. And then we can insist that others do. And so I'm going to ask, I think for my last slide, because this is how we get there. So myself and others have been advocating for this for a long time. So how do we get there is that we ask our national government agencies who use the words abuse that they need to change their name. Right. So we know that the word abuse increases stigma. We know that in many regards, it's not even an accurate use of the words. If you are a person with addiction like me, you know that you never abused the substance. You know that you loved it. You had a primary relationship with it. Abuse wasn't even part of the conversation. And so our institutions like the National Institute on Drug Abuse or the National Institute on Alcohol Abuse and Alcoholism or Substance Abuse and Mental Health Services Administration, you know, we have something that we would ask them. If you'd go to my last slide, please. It could look like this, right? It's not even a hard change. The National Institute on Drug Addiction, the National Institute on Alcohol Addiction and Alcoholism, the Substance Addiction and Mental Health Services Administration, that those are ways, right, you know, which would represent the top down. I mean, we have this huge push from those of us who are advocates and family members. We need those in government to do the same. As they are using some of these different words and asking us to use the different words, you know, the agencies and organizations can do likewise. And I actually have some really good news to share about that. Is one, there's the study that's been done about how the word abuse is stigmatized, and you can get that information from Dr. Kelly and from the Recovery Research Institute. They also have a petition that has gone out and around. I know Faces and Voices has been doing some work on it. Many years ago, I started my own little change.org petition. Didn't get very well, but get very far, but that's okay. What I heard yesterday when I had the opportunity to ask Dr. Volko a question, I learned a couple of things. One of which is that it takes an act of Congress to make that change. And I also heard, and it's recorded somewhere, is that both she and Dr. Koob support the change. Right. So we've got the heads on board, we've got the community and the advocates and the family members on board. And now we also have a champion in the legislator. Delegate Trone is going to be introducing some legislation that will go before Congress, insisting that the names be changed. So I thank you for allowing me to be here today and look forward to any questions that folks might have.
So I should unmute myself. Thank you so much. I know they're at the hour and folks need to leave, but we'll stick around for those who can. The action items I wanted to share with you was already mentioned by Jen. The change the name petition, please sign it. If you're an RCC director, please complete the survey so we can present nationwide what RCCs are and who they serve and how they serve. And then if you're inspired to do some research on any of the topics we talked about today, you know, apply for the pilot study funding. If you want to spread the news, apply for conference travel awards to, you know, mix your signs and present these kinds of information to the fields, especially the fields that haven't heard as much about it, and keep the signs going on recovery community centers. And with that, what are questions, comments, thoughts that you all want to share? And I think first off, we should do a round of applause for our fabulous presenters. It has been absolutely wonderful. Thank you, guys.
We should unmute for a pure applause. You can hear it.
So I know in the chat we have a very lively discussion, and just as a reminder, we will actually take the text version of it and put it on the website as well. It's going to get circulated early next week, so you can read through that. There was a lot of discussion about, has this been looked at, and yes, and links to studies and so forth. So all of that information will be captured in the chat as well, and of course the splits will be ready as well. I see Noel, were you raising your hand?
Yeah, absolutely. Thank you so much. Really great job today. I have a question that is specific to Dr. Weiss, or I don't even know if it's really much of a question, if you can just kind of comment on it. So first of all, I'd like to thank you so much for doing the POTS study. I did my dissertation as a secondary analysis of the POTS study, and so very appreciative of that work. I'm definitely much more hesitant on the findings around that counseling doesn't add anything. What I find to be the case, and this is just in my experience in recovery and then also in the research as well, is that polysubstance seems to be the norm rather than the exception to the rule. And so when you just look at relapse to opioids, you're really missing a part of the larger picture, which is that these individuals are oftentimes addicted to more than one substance. And so when we say that counseling doesn't work, or when we say that counseling has no effect on medication management, again, I think we tend to be kind of missing that part that you know, these people have polysubstance use, and especially when we don't have medications to treat things like cocaine use disorder and amphetamine and methamphetamine use disorder. And so I'm curious if you can just kind of speak to that general statement that you know, counseling doesn't work. When you know, I find it hard to believe that a lot of times I do think that it does help if we were to expand beyond just looking at medicate or relapse to opioids.
So it's a great question. It's one of the problems with having to shrink what is typically an hour talk into about 45 seconds. So I could mention that there are a number of studies that have shown that adding counseling to buprenorphine and medical management did not improve outcome, but there's like 100 asterisks and parentheses, none of which I could get into in that one slide. So just to mention what some of those are, what was medical management in these studies? It was called medical management, but I would reterm it medical counseling. There was a lot of counseling that went on in those medical management visits. They typically are done by sort of the very best clinicians around, because they're the people that tend to be interested in participating in these studies. They're the people that investigators want to have. So you've got that part of it. It's done typically in these studies much more frequently than it's done in typical community practice. So you've got greater intensity, extraordinarily high quality, lots of counseling built in. So you've got all of that. The definition of success in most of these studies really does focus on opioid use. So your point is very well taken. While the counseling focused on all use, the primary outcome was opioid use. You know, these are studies looking at different lengths of buprenorphine. We're not expecting that that's going to necessarily, you know, to touch their cocaine use. It would be nice, you know, we hope that, but buprenorphine is not a cocaine drug. So that's number 2. Number 3, secondary analyses, and it might have been one of your secondary analyses, have shown that some subgroups of that, the fact that in general, a treatment doesn't work doesn't mean that it doesn't work for everybody. That there are certain subgroups of people for whom it really does work. So we found people with psychiatric illness, they did better. People who used, so in the prescription opioid addiction study, we ruled out heavy heroin users. You know, we wanted to look at prescription users. So it was, so we had a quarter of the patients had used heroin, but they'd never injected heroin. They'd only dabbled in heroin use. But if you had ever used heroin, you did worse, except if you got counseling and went to counseling. So it made a difference for them. Specifically, PTSD patients did better with counseling. So, you know, in a primary outcome paper, you have to write down what your primary outcome is. But sometimes you, and you know, and so, but ours wasn't the only study that showed this, you know, so it's not like our study was an outlier. There've been a bunch of studies that have shown that. Now, why is that? Well, to some extent, because when you have an effective medication, it makes such a big difference that counseling's got to really be wildly effective to do better than that. You know, when you've got, for example, the difference in the Sublocade study between 28 and 2%, that, you know, 28 is what I would say is a not very good number. But when you compare it to 2, it's pretty extraordinary. So when you've got something that's that effective, something else has to be really effective to go on top of that. You know, to use an example that's not like this, but, you know, if you have strep throat and you get penicillin, there's no intervention on top of that. You know, do you gargle? You know, will gargling be helpful? Well, you don't need it because you've got such an effective medication. Whereas gargling can be good for a sore throat, but not if you've got a medication that's going to really treat it. Buprenorphine is, you know, we're talking about 98%, not 28%. So there's that. And I could go on, you know, with other things, but, you know, the point is that these things get distilled into one sentence results that are, and people interpret that study, it's like a Rorschach test, how people interpret that study.
So much.
Depending on who's listening to it. If it's somebody who does counseling, they're very upset about it. If it's somebody that's doing a primary care doctor in a rural setting who can't find any counselors around, they go, thank goodness I don't have to find a counselor. So anyway.
Yeah, thanks so much. And that study's, like I say, is great.
Excellent points. Other burning questions, comments, or thoughts? Or more asks to a multi-stakeholder group of what next to tackle, what to improve, what to do better? If not, we can go off into the weekend. I do thank you all.